Assalamu alaikum wa rahmatullah. Good morning, good afternoon, and good evening, everyone. My name is Dr. Mahmoud Al-Soufi. I'm a consultant pediatric cardiologist and the director of Heart Center of Excellence at Al Jalila Children's Specialty Hospital, Dubai. And it's my pleasure and honor to be with you today in BCSI 2022. I would like to thank Dr. Amitabh for inviting me to give this presentation about a big question. Every VSD with aortic valve prolapse should be closed. Let us go together and discuss this hot topic and conclude what will be the best recommendation. This is the content of my presentation. To start with, as you know, VSD is still the commonest congenital heart disease. It comes either an isolated defect or part of the complex defect. The clinical manifestation depends on the size, location, age, vascular resistance, and the rate of spontaneous closure also depends on the size and location of the VSD. This diagram just showing us the location of anatomically of the VSD, the commonest one, perimembranous VSD, the outlet or subpulmonary VSD like TOF type and 5 to 7%, the inlet type like AVSD and 5 to 7%, muscular VSD usually either isolated or multiple like Swiss cheese VSDs. When to close the VSD? I think this is a common question, but without any clear definitive final answer. Of course, when to close, it depends on the size of the VSDs. Big VSDs should be closed early. Small VSDs, moderate VSDs, patient may kept under observation morphologically. Is it perimembranous? Is it muscular? Inlet, outlet? Of course, if the VSD it's outlet or inlet, there is no chance for spontaneous closure comparing to muscular VSD. The timing it depends also the symptoms of the patient. Age, is there any specific age? Shall we wait weeks, months? Bigger age is better. If we can wait, smaller age can be done also if there is an indication. Same for the body weight. Bigger patient carries better outcome, but however, we can close those VSDs sometimes in early infants or even neonates in case of the patient remain symptomatic. Symptoms also uncontrolled symptoms, we have to close the VSDs. Controlled symptoms, we can wait. Spontaneous closure, of course, those who has a small or moderate VSDs, especially the muscular one, with a chance of spontaneous closure, we may give the patient this chance and keep him or her under observation. There is a general agreement about closing the VSDs in patient who has persistent symptoms in spite of maximum anti-failure medication, patient who has a VSD moderate or large, and signs of pulmonary hypertension, patient with significant left to right shunt, QP to QS more than 2 to 1, even if the patient remains asymptomatic, or those who has less left to right shunt like 1.5 to 1 with symptoms, subpulmonic and membranous defect with aortic valve prolapse and aortic regurg. Of course, we'll focus mainly on this group in the coming slides. And VSD with DCRV, we have to close the VSD and relieve the obstruction at the mid-RV cavity. So what about VSD, subaortic VSD with aortic valve prolapse? The mechanism of the prolapse, as you know, and according to Venturi effects, the high velocity left to right shunt through the VSD, it will suck the nearby soft tissue like a right coronary cusp mainly inside the VSD hole and create deformity of the valve, then varying degree of valve regurg. Most of those VSDs, or those patients, they don't develop a pulmonary hypertension because the sucked cusp inside the VSDs, it will restrict the left to right shunt. So most of them, they will have QPQ is around 2 to 1, not more than that. And some of them, they have 1.5 to 1. The mechanism is the sucked cusp inside the VSD. It will restrict the left to right shunt, as you know, and make it less significant. But at the other hand, there is a risk of aortic valve deformity and development of aortic valve regurg. Of course, most of those patients, they will develop aortic valve prolapse first, then later on aortic regurg, and the lack of the supporting tissue, as you can see, there is no tissue to support the cusp from prolapsing and to stay strong against the high velocity left to right shunt, and this will lead to a prolapsed cusp, then aortic regurg. So the risk of aortic cusp damage always there in those patients. This is an example of a patient who has big VSD actually. This is a VSD and this is the cusp sucked inside the cavity of the VSD. If we run the video, you can see that the shunt, left to right shunt, it's not that significant. As you can see from the rigid, but the total cusp was sucked inside the cavity of the VSD and the aortic valve got damaged, and you can see there is an element of aortic valve regurg. So why to close the VSDs? Let us review some literature. This paper from Saudi Arabia about predictors for the outcome of aortic regurg after cardiac surgery in patients with VSD and aortic cusp prolapse. This study was done in Saudi Arabia, and they studied 45 patients with VSD and coronary cusp prolapse. 5 of them, there was no aortic regurg. 25, the degree of the regurg was less than mild or equal to mild. And let us focus mainly on this group because this is a debatable group with minimal or mild regurg. Shall we close or not? They found that 19 out of 25 the regurg improved and 6 patients remain as it is, while those patients who has of course a higher degree of regurg, the chance of improvement were less. And this diagram also shows the same information. Those who had before a mild regurg, as you can see the red component here, the chance of improvement was much higher than those who has moderate to severe regurg. And they conclude early surgical closure is advisable for patients with VSD and associated valve prolapse to achieve a better outcome after repair and to prevent the progression of aortic regurg in the future. Another paper about the incidence of aortic regurg in association with the type of the VSD and its immediate and intermediate outcome after surgical closure. On the right diagram, we can see that most of the regurg occur in those who have perimembranous and supracrustal VSDs comparing to the muscular one. And on the left side, for those who have or who had before trivial to mild aortic regurg, the regurg either increase slightly immediately or remain as it is. Or those who have moderate regurg, the regurg either increased or remain as it is or even increase in the future. So this reflects that we have to think seriously about the early closure for such type of VSDs. And they conclude that once the aortic regurg develops, its progressive nature is associated with significant mortality, and it became high unlikely that the VSD will close spontaneously. So that means what we are waiting for, the VSD will unlikely to be closed spontaneously. The chance of valve damage will be higher and higher, and they suggest early surgical intervention. And the closure of the VSD before the development of cusp deformity will prevent the development of aortic regurgitation in the future. So early surgical correction is advisable in those patients to prevent the aortic valve deformity and aortic regurgitation in the future. Another paper about analysis of indication for surgical closure of subaortic VSD defect without associated aortic cusp prolapse and aortic regurgitation. This study was conducted on 214 patients. 75 patients, they had no aortic regurgitation before and no aortic regurgitation after closure. But what about 139 patients? They were asymptomatic. They managed by medical treatment conservatively without surgical intervention. And they followed those patients and they found that 73 patients, they developed aortic cusp prolapse. And out of those 73 patients, 78 patients developed aortic regurgitation. And the rate of aortic regurgitation and cusp prolapse in the future after 1, 5, 10, and 15 years, of course, it was increasing from 8 to 30, 64, and then 83%. So they conclude that subarterial VSD, when the defect is 4 mm and above, should be closed as early as possible to prevent the development of aortic cusp prolapse and aortic regurgitation. And this diagram also compare the freedom of aortic cusp prolapse in the future from aortic regurgitation in the future and the progression of aortic regurgitation in the future. So most of them, the chance will be much higher in the future if we did not close the defect as early as possible. What about the outcome of surgical closure of doubly committed subarterial VSD? In another paper, they found that the surgical closure of the VSD, if performed before the onset of AV deformity, may prevent the progression of aortic regurgitation. And if the aortic valve repair is performed after the onset of AV or aortic valve deformity, the progressive aortic regurgitation may not always be prevented. So this is regarding the protecting the valve from the damage and closing the VSD earlier. What about the risk of bacterial endocarditis? This is one of our patients actually. He was referred because of prolonged fever for unknown reason. He was followed outside for a small VSD restrictive because of the prolapsed cusp, restrictive shunt. And we found that, as you can see from here, there is a big vegetation attached to the tricuspid side of the VSD and another vegetation attached to the damaged aortic valve, as you can see on the right side. So the risk of bacterial endocarditis always there also. So the risk of damaging aortic valve, the risk of bacterial endocarditis, as you can see even in this paper, they found that there is a bacterial endocarditis in 5th decade in those patients who has even a small subarterial VSD. So the risk will remain as it is. How to close? Surgery always available to close all types of VSDs. So what about other modality? This paper about the comparison of device closure in the cath lab and surgical closure of perimembranous VSD, meta-analysis, they compared the major complication rate, the risk of the heart block, the risk of residual shunt, and finally they conclude that there is no significant difference between the pericutaneous, that's mean device closure, and the surgical closure of perimembranous VSD from the efficacy and the safety. in well-selected patient, because of course we cannot close all those phases in the cath lab. Furthermore, device closure is associated with decreased hospital stay, which could potentially reduce the cost of the procedure in those. Another paper compared the pre-ventricular, like a hybrid procedure, transcatheter and surgical closure of perimembranous VSD meta-analysis, and they conclude that periventricular device closure technique not only reduce the risk of significant complications comparing with the surgical closure, but also produces not inferior result compared to the transcatheter device closure for perimembranous VSDs. And these techniques appear to be safe and effective for selected patients. So we can close transcatheter, we can close periventricular plus surgical. Not only that, there is plenty of papers actually. This is another one comparing the transcatheter versus surgical closure of perimembranous VSD in pediatric age group, and they conclude that transcatheter closure of perimembranous VSD in children was an effective as surgical closure with a lower risk of serious complication of the open heart surgery and less need for blood transfusion and shorter hospital stay. Another paper supporting the same idea about closing those VSD even in doubly committed type VSD. Nowadays we have plenty of devices in the market. As you can see, we have the coil, soft coils, we have soft devices, we have a new design of devices like MFO. So you have vascular plug. So you can select the most suitable device according to the anatomy and to the center experience. And these create or give the main operator wide range of opportunities to select more than one device, fitting more types of perimembranous VSDs, and a softer device now, vascular plug 2, which is very soft, and it can avoid the risk of heart block and compression on the adjacent structure. And there is a lot of, I think, this paper also confirmed the safety and efficacy of using a Platzer vascular plug 2 with very high success rate, and there is no evidence of outflow obstruction, rhythm abnormality, and hemolysis. And this is one of our patient. Actually, you can see how close the VSD is to the aortic cusp, and almost the defects sitting beneath the aortic cusp. And this is a device after deployment. I can show you how we deployed the device safely below the cusp, and then we tested the aortic root. There was no aortic regurg. Then we released the device successfully. So we have wide range of options, non-surgical options to close the VSD in the cath lab. So to conclude and take home message, should we close subaortic VSD? The answer is yes. And why to wait? And the risk of aortic damage almost always there. And why to wait if there is no guarantee of improvement? So what we are waiting for? Do we think that the aortic regurg will improve in the future, or there is a chance or high chance of spontaneous closure? Of course, there is no high chance of spontaneous closure. And why to wait? And the risk of bacterial endocarditis almost always there. And finally, why to wait if we can close a good number of those defects nowadays out of the operation room in the cath lab.